Hello and welcome back to the Academy of Anaesthesia. In this two-part series, we will be discussing a topic that's highly relevant to both the primary and the final parts of the FRCA exam and clinical practice. That is, of course, depth of anaesthesia monitoring and accidental awareness. To cover the exam content, we will go over the classification of the methods of depth of anaesthesia monitoring. We will then focus our discussion around EEG-based methods of monitoring. And then in part 2, we will dive deep into BIS monitoring specifically, discuss accidental awareness, the risk factors including the NAT5 study, and how to manage patients who have had an awareness experience. There is a lot to go through here, so let's get started. To start off, we need to outline the stages of consciousness and awareness. In an unmedicated state, the human being is classed as awake, unsedated, or alert. Once medication is used to affect the level of consciousness, we can follow the simple table from the American Society of Anesthesiologists, which provides a very structured and easy to follow approach to describe the different levels of sedation. Below awake, we have minimal sedation, and then moderate sedation, also known as conscious sedation. Next is deep sedation, and then finally we reach general anesthesia. Note that the table distinguishes between these different states by 4 parameters on the side, which are responsiveness, airway, spontaneous ventilation, and cardiovascular function. This table is very useful in understanding the changes that occur at each stage of sedation. Pause the video and have a read for yourself. I'll add a caveat in that if a patient has a comorbidity that affects any of the 4 parameters, then this will need to be taken into account when trying to assess the level of sedation. The table stops at general anaesthesia. However, if you were to deepen anaesthesia further, you reach a state which is known as a deep hypnotic state. Continuing further, we can only really distinguish using EEG-based methods, and so you then have an increasingly burst suppressive state until you finally reach cortical silence, where no EEG activity is detected, a state sometimes seen in brain death. We'll revisit this spectrum later on in the video when we discuss EEG-based monitoring methods. In order to classify different methods to monitor depth of anaesthesia, we can use 2 broad categories, non-EEG based and EEG based methods. The groups are fairly self-explanatory. The non-EEG based methods include a range of monitors. The ones we will discuss in a bit more detail are physical examination, isolated forearm technique, lower esophageal contractility, and end-tidal anaesthetic agent monitoring. EEG based methods include processed EEG, and auditory evoked potentials. There are lots of other methods to determine depth of anaesthesia, but they are either research-based or not used in clinical practice. You don't need to know those for the exam, and so I've not included them in this video. Let's quickly go through the non-EEG based methods before discussing the more important EEG based methods. Physical examination and clinical observations are by far the simplest and include all the things that we monitor already in the operating theatre, including respiratory rate, saturations, heart rate, blood pressure, movement, eyelash reflexes, and responsiveness. You might have already noticed during your own anaesthetic practice that the heart rate, blood pressure, and respiratory rate might rise if a patient is in a lighter plane of anaesthesia. If a particularly stimulating event occurs, the patient may move or cough. This is the quickest way and simplest way to understand if there is a mismatch between the required depth of anaesthesia and the surgical stimulus being applied. Goodell's stages of anaesthesia is a structured approach to this method. Although some consultants out there will insist you learn these stages and the clinical signs associated with them, they are not necessary to pass the exam. It's a classic method of measuring depth of anaesthesia and was originally developed to work with ether-based anaesthesia. Next, we've got the isolated forearm technique, or IFT as it's more commonly known. This technique relies on the principle that if you apply and inflate a tourniquet to an arm before inducing the patient, the medications given through the other arm will not affect the tourniquet arm. So, if the subject is aware enough, they will be able to respond to commands and move the hand in order to signal awareness. This is considered the gold standard method of monitoring for awareness, but it's not widely used in day-to-day anaesthesia. In fact, the NAT5 study, which examined accidental awareness under general anaesthesia, showed that only 0.03% of anaesthetics given in the UK used IFT. There are significant limitations to this technique in that there is little correlation between post-operative recall and being able to respond to commands. In other words, even if a patient does respond to your command, there is little correlation that this will mean the patient will be able to remember the events of the surgery explicitly. There is also some controversy in whether inflating the tourniquet for more than 20 to 30 minutes can cause ischemia-induced paralysis, thereby giving you a false negative. Some techniques have been developed to try and mitigate for this, but the controversy still remains. Despite this, it is considered the gold standard for depth of anaesthesia monitoring, the standard against which all other monitors are assessed, and so is something you need to know for the exam. Moving on, the only thing you need to know about lower esophageal contractility is that using a balloon catheter placed at the lower esophageal sphincter, you can measure the contractility which is influenced by stress and anxiety. By using an algorithm, you can convert these pressure waveforms into an esophageal contractility index, which supposedly produces slight correlation to the depth of anaesthesia. If you Google lower esophageal contractility, on the first page I couldn't find a single link to a paper from beyond the 1990s, and that should tell you everything you need to know about its use today. It does appear in some recent exam-focused textbooks, and so I've included it here just for completeness. Finally, within the non-EEG based methods, we have end-tidal anaesthetic agent monitoring. We won't go into the physics of how it's actually measured, as that's a separate topic within itself, but it's the one you're most likely to be familiar with as it's on every anaesthetic machine. It's important to know the definitions of MAC, or minimum alveolar concentration, so I'll leave this in the description below. There are many factors that will affect the MAC, but there is no single figure to target that will prevent intraoperative awareness. The MAC requirement to prevent awareness will also fluctuate from moment to moment in the surgical procedure, so it's important to understand that MAC only measures the drug concentration and not the brain responses. This is reflected in the definition of MAC, which makes no mention of the level of consciousness or awareness. Moving on to EEG-based methods, we have one of the most important ones, which is processed EEG. If the opening question is to classify the different methods of monitoring depth of anaesthesia, it's more than likely that the question is heading for processed EEG and awareness. We've already mentioned about how the brain can produce EEG waves. By placing electrodes on the forehead during anaesthesia, you can pick up EEG waveforms produced by the electrical signals in the brain. The waveforms correspond to the level of consciousness and the depth of anaesthesia. This is a pictorial representation of the different types of waves seen on EEG. The different waves at different frequencies get classified into 5 different classes. A tip to remember in decreasing order of frequency is to remember the mnemonic "Great brains achieve through dreams," which corresponds to gamma, beta, alpha, theta and delta. Feel free to make your own mnemonic to help you remember. Now, you can look at the raw EEG data without any processing and derive information, but it takes years of expertise and practice, and so it isn't feasible for anaesthesia. However, by processing the EEG and analysing it, companies have produced an algorithm that can convert the signal into a dimensionless number which goes from 0 to 100. This is much easier to interpret. There are 3 main companies which produce process EEG algorithms and their monitors. The monitors include BIS, Entropy and Narcotrend. All 3 monitors follow the same principles. They all use electrodes placed on the forehead, they all use an algorithm to process the EEG, and they all produce dimensionless numbers from 0 to 100. BIS stands for Bispectral Index. It's the most commonly used EEG-based monitor in the UK. 4 electrodes are placed on the forehead to produce a dimensionless number between 0 and 100. Above 90 is awake or alert, between 60 and 90 is where post-operative recall is possible. Between 40 and 60, it's classed as a surgical plane of anaesthesia, where the probability of explicit recall is low. In this plane, the EEG often looks like a slow wave which has a high frequency wave superimposed, the so-called alpha-delta pattern. Below 40, the patient is over-anaesthetised, and this can be seen by burst suppression seen on the monitor. It looks like a flat line with periods of high activity. If you look back to the sedation spectrum from the beginning of this video, we can match some of those EEG patterns to those states. Most anaesthetic agents will produce similar changes in EEG waveforms as described just now, and so BIS can be used in most anaesthetic techniques. However, ketamine and dexmedetomidine change the EEG power spectrum, which influences the way the BIS monitor analyses and interprets the EEG, and so will affect the overall number produced. The other drug to note down is nitrous oxide, which doesn't affect the BIS number at all, and so if you use it and rely on the BIS number, you might unintentionally keep the patient deeper than necessary. We'll be going over the current guideline recommendations and a more detailed analysis of BIS in the next video. Entropy is another form of processed EEG by a different company, GE Healthcare. The name entropy is based on the principle that as you increase the depth of anaesthesia, the disorder found in the EEG signal decreases, i.e. the entropy decreases. A highly irregular signal means high entropy and therefore the patient is likely to be awake or alert. The more ordered the signal, the less entropy, and therefore the patient is likely to be anaesthetized. There are two numbers that it produces, response entropy and state entropy. It is very similar to BIS where the target range is between 40 and 60. Unless you're interested, you don't need to know more than this for the exam. Last of the processed EEG monitors is Narcotrend. The only difference between Narcotrend and the others is that it produces one number and one letter. The number is dimensionless like BIS and entropy where 100 is awake and 0 is no activity. However, the letters range from A through to F, where A is awake and F is no activity. The Narcotrend stages, D or E, are assumed to be equivalent of BIS values between 60 and 40 respectively. Finally, let's briefly mention auditory evoked potentials or AEPs. AEPs were developed on the principle that the response to auditory signals disappears last when undergoing general anaesthesia. You can deliver clicks that can trigger potentials on the EEG to signify responses to auditory stimuli. Anaesthetic agents decrease the amplitude and increase the latency of the signal produced. This is dose dependent but agent independent, and therefore the responses can be analysed to give a numerical value which indicates the depth of anaesthesia. You don't need to know the numbers and so I've not included them. It's not very commonly used in anaesthetic practice, but it's more common in neurophysiological studies. And that's all you need to know to discuss depth of anaesthesia monitors in the exam. To summarise, we've discussed the spectrum of sedation, extending it beyond general anaesthesia. We've gone over how to classify the methods of monitoring depth of anaesthesia, as well as outlining the key advantages and disadvantages about each. The reason why we have to learn about so many different types of monitors is because there isn't a single monitor that allows us to accurately and reliably monitor consciousness and depth of anaesthesia. So the advice remains that all the monitors available to us should be used in combination rather than using a single piece of equipment to determine the depth. One day, when we've solved the hard problem of consciousness, we'll have a perfect monitor, but until then, we'll have to make do. As usual, the references are in the video description below. I hope you found the video useful and thank you very much for watching.